All right, good afternoon. Welcome to the Medical Association of the State of Alabama. My name is Aruna. I'm the president. And I'd like to welcome our two guests for this week. We've got Dr. Scott Harris, of course, our state health officer, and we've got Dr. Tate Hinkle, who is a rural family physician who is here to help us debunk some of the misinformation that is out there. So anyway, why don't we go ahead and start? Dr. Harris, if you want to go ahead and give us an update.
Sure, I sure will. Thank you very much, Dr. Arora. It's good to be on with you again this week. As we get started, I just want to remind everyone who's viewing that we've been doing this for a few weeks now at this time on Thursday afternoons. We'll be back next Thursday as well. So we appreciate you taking time to join us, and just we hope this is a great opportunity for you, like it is for me, just to hear from our physicians here in the state about what they're seeing related to COVID and gain the benefit of all their knowledge and experience. So I do have some news that's not great about the state. We are seeing increasing numbers of folks in Alabama hospitals, again, that is really increasing about as fast as we could imagine. We've been alluding to that the past 2 or 3 weeks, but as of yesterday, we had just under 2,800 patients in the hospital. That number is going to be pretty similar for today that are confirmed to have COVID. And there's probably another 100 or so that are suspected of having COVID that we're just awaiting results on. The number of ICU beds we have available in Alabama is 0. We do not have any place for additional ICU patients in our state. There are a number of hospitals, particularly in the southern part of the state, that have adopted other space in the building to take care of critically ill patients, like regular floor beds that they've converted into an ICU bed, or in some cases, they're holding people in the emergency department. So we actually have a negative number of ICU beds. We have more patients receiving critical care than we have critical care beds. And we never really had that situation even back in January when technically we had a few more people in the hospital than we're seeing right now. So that's very discouraging for us. We've started to see COVID daily case numbers go up to the range of over 4,000 a day. We've had that 3 of the last 4 days. And those are, again, as high as we have seen. That really begins to affect the way a lot of people do business, if you will. We've had ambulance crews that have been affected by this. We've had hospital staff that have been affected by this. So some of the really important pieces of our healthcare system are really being hampered, not just with the patient care they're giving, but also with the amount of COVID they're seeing among their own staff. So that's a really difficult time for us right now. We have seen somewhat of a bump in vaccinations. We are happy to be able to say that. The last couple of weeks, we've been averaging somewhere between 14,000 and 16,000 vaccine shots per day. About 2/3 of those are new shots, or people getting their first shot. So that's definitely a lot better than we were even 5 or 6 weeks ago, when we were seeing sometimes 4,000 or 5,000 shots would be a pretty normal day then. So we're encouraged that people are doing that. Of course, if you're getting your first shot today, remember your second shot with Pfizer or Moderna is going to be 3 or 4 weeks from now. There's a couple of weeks in order to get to full immunity beyond that. So people getting vaccinated today, we really don't realize the benefit of that, for about 5 or 6 weeks. So please don't wait. If you're wondering whether you need to get vaccinated, well, this is why we have doctors like Dr. Hinkle on today to talk to you about that. And we certainly always want to remind you to talk to your own doctor as well, the person who knows you and your family the best. That's the person who can give you the best advice about what you need to do to keep yourself and to keep your family safe. So I will say just one last thing, Dr. Arora, we have been working with our federal partners to try to find some staffing for some of our hospitals and to staff some centers for administering monoclonal antibodies. We probably will finally announce all that publicly tomorrow or perhaps Saturday, but we do expect to have a couple of teams at least coming into the state later this week. We do hope to have some additional sites for monoclonal antibody infusion centers going up pretty soon as well. So that is one good thing that we are looking forward to talking about. So that's just kind of my update there, and I'll be glad to answer any questions or pass it back to you.
Yeah, so I guess a couple of things that people have been asking. One is the monoclonal antibodies. and the criteria for people who are exposed. Can you go over that for us?
Sure, absolutely. So, that's an interesting new thing that we've just been talking about for a couple of weeks. I think most people are probably aware that these monoclonal antibody treatments can be used in people who have gotten infected, but who are at high risk for getting really sick. So for people who are seniors, for people that have chronic health problems, if we're worried about that being somebody who may end up in the hospital, you can use these monoclonal antibody infusions, just a little, 20 or 30-minute infusion, and that really reduces their risk of keeping them out of the hospital. But as Dr. Arora mentioned, we also now are able to use the drugs to prevent illness in people who've just been exposed to COVID, but actually haven't gotten sick yet. They're people that aren't even known to be infected yet. And what we call that in the medical world, post-exposure prophylaxis. Once someone's been exposed, afterwards, we try to give them this medicine to prevent that. Again, it's actually for the same group of people. It's for people that are at high risk if they were to become sick and to get infected. If they were to get infected, it's for people age 12 and up, but most of our high risk people are probably not going to be kids or adolescents. There may be some that are at high risk, but they tend to be people who are seniors, who are older, or people that have other chronic health problems. And so that is another option. These antibodies don't have to be given as an IV. They can also be given as just an injection under the skin. So it can be done in a doctor's office if your doctor is someone who's interested in doing that.
That's a good update, Dr. Harris. Another big issue that people have been really concerned about, of course, is K through 12 schools being in session. Any comments regarding mask guidelines and how to keep those numbers down, along with quarantine protocols?
Sure. Yeah. Really, our guidance hasn't changed since last year, and for the most part, the best way that we have to keep cases from spreading in schools, or for people to get vaccinated if they're eligible to do that, and to make sure that we have universal masking in our schools. We want everyone, kids of all ages, as well as adults, educators, teachers, and school officials, to be masked when they're around other people, to the extent that you can do that. For kids age 12 and up, we have vaccinations as well. And so we certainly want to encourage them to be vaccinated. When we have a case that occurs in a school, we send that person home who's infected, who has symptoms, but we also want to send home anybody who's a close contact to that person. So the definition of that is if you've been within 6 feet of someone who's a case for 15 minutes or more total, then we want you to go home for about 10 days as well, because there's a very high likelihood, especially with this infectious Delta variant, that you yourself could become infected. There are some exceptions to that. There are some people that don't have to quarantine. And the main one is if you're vaccinated. If you've been vaccinated and you're exposed to someone, you don't count as a close contact. You get to remain in school. Also, for school kids who are at least 3 feet apart and who are consistently wearing masks, when everyone's wearing masks, we don't call those people close contacts either if they're exposed to a case. So another good reason to try to maintain distance and try to wear a mask if you can do it. And there is another group, if you've actually had COVID within the last 90 days, the chances of you getting it again in 90 days are very low, so you don't have to quarantine as well. So those are the main things that we're trying to tell schools. We have seen a jump in numbers in that age group. We've had about 4 times as many 5 through 17-year-olds become infected in COVID as we saw a year ago at this time, just looking at the first 2 or 3 weeks of August. So we know that those numbers are on the rise among school kids.
Yeah, that's great that you clear that up, because there are stories out there of situations where COVID positive children, if they're unvaccinated, can remain in school. So I think you have nicely cleared up and pointed out the CDC guidelines as of current that we are recommending for schools to follow. So that is really helpful. There was a group of advocates and physicians and various experts that came together to describe how to open schools safely in the nation. And sadly, one of the slides that they showed was Alabama, and they showed how steep our curve was for being in schools. So the last thing we want to do is be a social experiment here. Every child's life is an important one right now, whether they're in the hospital or whether they develop long COVID. We certainly want to protect them. Thank you for that update, Dr. Harris. Dr. Hinkle, let's go ahead and start debunking some
Let's
stuff.
do it.
What do you want to go with first? Why don't we go with the, I'm waiting for FDA approval.
Yeah. So we've heard that a lot. So currently right now the vaccines have what's called emergency use authorization. What that basically means is they went through a safety trial, and they went through very large safety trials and were proven to be safe and effective. And then the data was all reviewed by the FDA. And then the reason why they didn't wait for full approval was we need to get the vaccine out to people. And so it did go through a very the same rigorous process that all vaccines go through to be looked at before being given emergency use authorization. So they have been reviewed by the FDA and proven to be safe. And if you look at the numbers, I mean, I was just looking earlier today, I think around in the world, a total of close to 2 billion people have been vaccinated at this point already. And so that kind of shows you that there's a lot of people that have been vaccinated, and the amount of side effects, serious side effects that we're seeing with it are very small. And I think maybe Dr. Harris has a better idea about when the FDA is going to fully approve it, but it's coming soon probably. But it was evaluated, it was looked at, so it is safe.
And go ahead, Dr. Harris.
Sorry, I didn't mean to jump in. Yeah, Dr. Hinkle is exactly right. And we actually had a conversation today with our federal partners in Washington about that. We don't know exactly when full approval will come, but we expect it'll be really almost any minute. We've been thinking it was going to be by the end of this month, but it certainly won't be much longer than that. As Dr. Hinkle said, we're going to have more safety data on this vaccine at the time it's approved than any vaccine ever in the history of the FDA, or even any medication. We've had over 200 million Americans have received vaccine injections to this point, and they're still looking at all that safety data to approve it. So when it gets approved, I'm confident we will know more about the safety data of this than anything ever in our history.
Absolutely.
Absolutely.
Dr. Hinkle, what about patients saying that there is a microchip getting inserted?
So yeah, that's one that I've heard. I haven't heard a lot of that, but I have heard some. And I think where that came from was when it was originally being talked about. The federal government was talking about they wanted to know where the vaccines were going. They wanted to make sure that the vaccines were going to places that people were going to give them. And so they have, from their standpoint, wanted to know, okay, Alabama's getting X amount of vaccines. How many have they given? So that they know where to give resources to places that are giving them. But as far as, we've given countless shots in our hospital, at our office. I've had both of mine. There was no microchip in there. It's it's not like what we do with our dogs, and they have their little microchips to, if they get lost. The needle's not big enough. I mean, the needle is barely enough just to get the liquid through and go into the muscle. So there is no microchip in that vaccine, but I think that's where it came from. I think that's probably where that myth probably started.
Yeah, and I think a lot of healthcare workers have been trying to at least say, the cell phone itself is essentially your microchip. It's not the vaccine that you should be concerned about. Can you speak to, in our state, we've had a lot of people who are currently naturally immune to COVID, meaning that they have caught COVID at one point in time. Can you speak to the need to get a vaccine, and how you can explain to these patients that would give them some added protection?
Right. So that's probably one of the biggest things that I've heard from patients is I've already had COVID, and so I don't need to get vaccinated. But as Dr. Harris just mentioned a few minutes ago, we know that for about 3 months, you have a pretty good, robust immune response to protect you from a reinfection. But that does go down over time. And especially when we have variants, especially like the Delta variant, that is different than the original COVID that many people were infected with in 2020 and earlier this year. There is a difference in those. And so your immunity from that is not as robust as far as when you had the original version of COVID. what I usually tell patients is what we've seen, both in our clinic and our hospital, and the data has shown is, you do have some protection from a previous COVID infection, but the vaccine itself is an even higher level of protection. And then if you actually combine both of them on top of each other, it is significantly higher than either one of them by itself. And so, we are seeing reinfections of people that had the original version, and we're seeing them now reinfected with the Delta variant. And sometimes they're just as sick or sicker than they were before. And so it is that much more important for people to get vaccinated, even though they have had COVID.
And are some of those patients who've now been reinfected with Delta able to tell you any difference between, the first infection and the second? Are they presenting, faster? Are they presenting sicker? Is there anything there to
yeah,
comment on?
what is interesting on the ground is that we're seeing a little bit different symptom profile from patients that I'm at least seeing in our area. Whereas originally it was a lot of the shortness of breath, cough, fever, loss of taste and smell. Now it seems to be more, a lot of people come in thinking, oh, I've just got a sinus infection. So they're having nasal congestion, headache, very, very commonly are the two most common presenting symptoms. We're still seeing a good bit of fever with patients that have it. As far as those people that are getting reinfected, haven't had a ton of them that have gotten admitted to the hospital. And so, most of them are saying it does feel like it's a worse a little bit more than the second time around. But we have not had anybody, at least in our hospital, that's been reinfected quite yet. We do have a small hospital. We only have a 6-bed ICU, which is now a 10-bed ICU. We had to expand on Monday. I was actually working last weekend, and there were 8 people in our emergency room with nowhere to go. And so we had no choice but to increase our ICU by 50% this week. So.
Can you speak to any patients that are hesitant to get this vaccine because of the fear that they think pharma is profiting off of these vaccines?
Mm-hmm. So I've heard that myth for years as a physician, not just with this vaccine. My first response to that usually is, well, if we also hear, hey, as physicians are profiting from pharma off of all that, and I usually say, well, if that's the case, I need my check because I haven't received it yet. So it would be nice, but jokingly. But the vaccine is actually being covered by the federal government. It's free to everyone that wants it. You don't have to pay for it. It was covered by your tax dollars, and so of course, they down the road, they may have, when we get years down the road, there may be some profit that the pharmaceutical companies make off of it. But for right now, I think the shots are $4 a piece or something like that. And all of them are free at any place you go get them. It's all covered, whether you have insurance or whether you don't have insurance. It's all free. You just got to roll your sleeve up and get a needle to put the vaccine in your arm.
And what about patients who are fearful that this is a means to have population control and keep people from reproducing and affect their fertility?
Yeah, so we've heard that a lot, especially with younger women, and I'm hearing it more now that kids are coming into the conversation about vaccines. I'm hearing it as a legitimate concern from parents, right? And I find that for most of these things, most people have a legitimate concern about these things that they're hearing, whether it be on Facebook or other kind of social medias or the news. And usually once we have a real conversation about what those things are, I've had lots of patients to say, well, you changed my mind. And specifically with those, the concern was, hey, it makes people infertile. And again, I think that came from when the trials were going on. They did recommend during the vaccine trials for those trial participants to not get pregnant because they didn't know what the effect was going to be at that point because they're undergoing the trial, correct? But if you look now, lots of women that are pregnant or have become pregnant have gotten vaccinated. And then the two major OBGYN societies, the American College of Obstetrics and Gynecology and the Society of Maternal Fetal Medicine, have both come out and said they think it is safe and they recommend it for pregnant women to be vaccinated. And so not only do they think it's safe, they actually say you should get it because of the effects that it can have on your pregnancy. And if anything, having COVID could potentially have long-term issues on fertility more so than any vaccine. It doesn't have any potential to affect anyone's fertility.
Okay. There is a question that has come in that I'm going to read.
Sure.
Adverse effects occur when the antibodies generated during an immune response recognize and bind to a pathogen, but they are unable to prevent infection. Instead, these antibodies act as a Trojan horse, allowing the pathogen to get into cells and exacerbate an immune response. Is it possible that future variants could trigger such a reaction?
So I have seen a video online that came up about that. There's a kind of an out there theory about I think it's a gain of function mutation or something like that. But what we know about vaccines that have been, I mean, we've been vaccinating people for a long, long time, right? The vaccines, what they do is they mimic an infection in your body to produce an immune response that your body then has the ability to remember. And so when you're exposed to that, then your body has a memory to say, I can fight this off. And what I usually respond to on that is, look, what we're seeing on the ground is exactly what the data is being reported. I can tell you from a daily standpoint, when I talk to patients, and I always ask them when they call me and say, hey doc, I've got COVID. I need to get treated. So we get them on the medicines. We try to get them the antibody infusion. I always ask them, are you vaccinated? Are you unvaccinated? It doesn't matter to me. At that point, I'm trying to treat them to get them better. And I don't want them to end up in our hospital. But about, probably about 75 to 80%, maybe even a little bit higher, are unvaccinated. And those people that are in our hospital are the ones that are unvaccinated. The people that are at home that are having very mild symptoms, and then within a few days, they're pretty much asymptomatic. Those are the people that are vaccinated. We have had one patient that was a personal patient of mine that was vaccinated in the hospital. But as I told him when I saw him out afterwards, I said, had you not been vaccinated, you probably would have not made it through this, because that was the only thing that got you through this. And he's still battling some symptoms, but and those, we know those breakthrough cases are there. We expected them. But what we're seeing is that the vaccine is protective both against getting an infection and certainly against hospitalization and death from COVID.
Yeah, no, those are good points. How do you counsel patients who think that there are stem cells and in these vaccines, and for reasons, pro-life reasons, they are really hesitant to take this vaccine?
Right. I actually had that one the other day with a patient as well. So this vaccine is not got stem cells. It basically, there's three vaccines in the United States, the two mRNA vaccines. Basically the way they work is they have a little piece of called messenger RNA. That's what mRNA stands for. And it's basically a little message that tells your body to make a protein. And in this case, it's the protein that's on the outside of the COVID virus called the spike protein, which a lot of people probably heard of. And it's coated in some fat or lipids. And that basically is all that's there, along with a few preservatives to make sure that it stays stable. And they can make those very rapidly with production facilities, a lot different than some of the older technologies of vaccines. But that's all that's in there. And that, goes into the outer part of your cell where it makes the spike proteins and releases those spike proteins. And that's where your body has the immune response. It never gets into your this part of your cells where DNA is made and replicated. So it's safe. And then the Johnson & Johnson is an adenovirus vector vaccine. So it uses a killed virus vector to get the same message into the body to make have an immune response. And so those are how they work. And we've known that for a long time. And again, they've proven themselves safe at this point. Like Dr. Harris said, we have more data on these vaccines than we've had of any vaccine before it got approved whatsoever. So
What about the patients who have so many serious medical conditions? And they are concerned that if they get the vaccine and they get the side effects, particularly after your second dose, because of all their medical conditions, they think their body may not be able to handle this.
Right. So I usually tell those patients, if you have a lot of medical problems, then I can tell you from our experiences, you need it more than anyone else, because your risk of having getting COVID and having severe COVID, hospitalization from COVID, death from COVID is that much higher than everybody else. I usually tell patients there are side effects of the vaccine. They usually include a sore arm. That's what happened with me. I had a pretty sore arm. I didn't feel so great the night I got my vaccines. The next day, I had a sore arm most of the day, and then I went on about my business. I've had lots of patients that have had a fever with the vaccine. Again, that's an immune response that your body's doing, mounting to produce the antibodies it needs to fight off the infection. And so for those people, yeah, you can expect 24, maybe 36 hours of not feeling good. But for the most part, I think those are much less than people think they are. And most people do quite well with the vaccine. Most of the time, it's nothing more than a sore arm and feeling a little achy or feeling a little bad.
Okay, what about patients who say that, there is saline in this injection and it is a placebo and I may not be getting anything?
Yeah. So obviously, yeah, it just looks like a plain liquid when it comes out. But I can tell you from myself, having had the vaccine, saline injection is the same fluid that's in your body. Our natural fluid is there, and that's why we see the immune response. That's why we see the pain. That's why we see sometimes the redness. That's why we sometimes see people get the fever or the body aches. That's because you had a medicine that was given to you that your body is using. So it's not a placebo. That's why I usually tell patients it's a good thing if you start to feel bad a little bit. That means it's working.
So to the patients who feel they are nervous to take this vaccine and they would rather just wear a mask, what do you tell those patients now that we are in the midst of a Delta surge with the frightening modeling and experts like Dr. Jeannie Marazzo saying this is apocalyptic, what could be coming our way?
Yeah. So I definitely think, wearing a mask is certainly a good thing, right? I wear a mask every day, all day long in my clinic. I wear it when I'm in the grocery store and things like that. But it's not 100% protective. It does reduce your risk of getting COVID. Obviously, it reduces the risk of transmission. We know that from many studies. I do hear from a lot of patients, well, the virus can get through the surgical mask and things like that because it's the particle size and stuff like that. And the virus particles are very small, but viruses don't transmit through the air and by themselves. They are carried on aerosols, which are much larger. And that's where the masks come into play when you're close into somebody. But while the masks do reduce your risk of getting COVID, especially if you're closer to people that have had it, the really only big protection is that vaccine, because it helps your body not only fight it off to not get it at all, but also, as we talked about, it really is showing really good efficacy at preventing you from getting serious COVID, which is that really was the goal of the vaccine to begin with, is to prevent people from getting seriously ill from this. Because as we're seeing right now in the state of Alabama, our numbers are past where they were in January. And unfortunately, we feel that they're going to continue to go up. And as we see on the ground, the people that are not getting sick are the ones with the vaccine.
Dr. Hinkle, could I jump in with a question?
Sure.
You mentioned earlier something about breakthrough infections. A question that we hear a lot, and I'd be curious to know how you answer it, is many people saying, I know so-and-so and they were vaccinated and they got infected anyway. So why should I bother getting vaccinated if I'm still at risk for getting infected? What would you tell a patient like that?
what I tell most of them or all of them, and I hear that's a very common one I hear too, Dr. Harris, is what's the point of me getting vaccinated because I can still get COVID, right? And I tell them, I'm not going to lie to you and tell you that it's going to 100% prevent you from getting COVID. But what I will tell you is everything that I've seen in my patients, which is, again, 75, 80% of them that are getting it right now, unvaccinated. Those people that are unvaccinated are getting very, very sick. They're the ones that are on the ventilators. They're the ones that are on 15, 20, 30 liters of oxygen in our ICU. Whereas all my patients that are vaccinated are the ones that are at home. And many of them that have had it, I've not had a ton, but the ones that I've talked to and seen back in the office said, I had felt like I had a mild case of the flu, and I had some body aches, maybe a headache. I didn't feel good. 3 or 4 days, I was back to normal, and I'm back on with my life. And so that's what I usually tell patients is that's the reality is, yes, still most people that get COVID are going to be okay, right? They're going to be okay long term. What I'm seeing, especially from the people that had COVID in 2020 and earlier this year, a fair number of patients, I would say on average, probably 10 to 15% of my COVID patients. Now, I do have an older population in my practice, but I have a lot of patients that are having what we call long COVID or long hauler syndrome. They're still on oxygen. They're having profound fatigue still. And I'm talking 6 months to a year later. I've had several that have had to have heart caths, stents put in their heart. Their lungs are much worse, or they did not have lung disease and now they do have lung disease because they had COVID. And while we haven't gotten far enough out from people that have breakthrough cases, I can almost see that those patients are not going to have long haul syndrome because they're already back to normal within a week or two of having a breakthrough case if they were to have it.
Yeah, we've heard some stuff this week about booster doses that the feds have been talking about, and I know there's been a lot of question about when those would be available. But I guess I've heard people say that sort of the same argument in a way, like, why, you're telling me I already need to get another one? This vaccine must not be that effective. Why do we have to keep getting vaccines if they're so great? What would you tell somebody like that?
Well, so right now, all we're doing is the boosters for those that are immunocompromised, because we found out that they didn't have as a robust a response to the vaccine because being on immunosuppressive drugs or an immunosuppressive condition like cancer, HIV, rheumatoid arthritis, such like that. But what I tell those people is, we have lots of vaccines that have had to have boosters. And that's just the way vaccines work. The body's immune response wanes, and we have to go through a booster series to keep your immunity up. We get a tetanus shot every 10 years. We get a flu shot every year. It takes 3 vaccine series to get your hepatitis B series. When you're a kid, there's I'm trying to remember from my residency, all my vaccine schedule stuff, there's multiple MMR vaccines, there's multiple DTaPs. So all that. So it's not an uncommon thing that we have to have boosters. One of the hard parts, I think, for the public right now is they're seeing science play out in public, and they're seeing it play out on a daily basis. Whereas we see this is what we do, right? And we know that data changes the way we see things, and we have to adjust and manipulate and do things differently but when we get new data in. And unfortunately, the public is seeing that happen now in real time, and they're probably not used to that. And that's probably giving them some probably scaring them a little bit, because they're thinking, why they keep changing their mind? Well, we change our mind all the time when we get new data, and we adjust things. It's just a lot of times you don't see that on the backside of what we see in medicine.
I think, Dr. Hinkle, you brought up a really great point, because that evolution of what the optimal information at the current time has definitely given people pause and doubt, seeing institutions like the CDC change from one minute to another without keeping in mind the evolution of the situation. So I think you're exactly right. Being a rural family physician that you are, can you speak to, the patient who, you know, is watching TV and hearing things and really nervous. Can you speak to those patients? You probably have seen those patients in your clinic.
Yeah, very much so. A lot of them are hearing these things. They're hearing these myths either through news, social media, and stuff like that. And I usually tell them, you know, I hear that you have concerns about it, and I have no problems with you having concerns about it. What I want you to always do is, if you have a concern about it, the best person to get more information from is me, right? Um, you know, it's not your job to try to understand complex scientific studies and stuff like that. Let me try to boil it down for you. And I think that's what I've seen. Like I said, you know, I hear from lots of people that ask me, because they know I'm a physician. They say, what do people say when you talk to them? What are their concerns? And I say, most people hear these things and they do have legitimate concerns, because they say, I want to talk to you about it. I want to know what you think about it. And the most common question I actually get is, have you had your vaccine? I say, absolutely. I was one of the first people in the state of Alabama. I had it the first week it was available. And some of them are shocked by that. And I say, my whole family has gotten it. I tell everybody I think they need it. And that does honestly mean a lot to people. And it means a lot to me when they come back to me and say, you know, doc, what you told me about, you changed my mind and I went and got the vaccine. That means a lot to me, because I just tell them, look, if you've got questions, and I'll walk them through, I'll say, what are your concerns? So let me try to help address your concerns. I want you to make a decision on your own whether or not you get the vaccine, but I want you to make it with good information. I want you to make it with correct information. I don't want you to make it with information that you get from somebody who doesn't know what they're talking about, or some social media post or something like that. Let me give you the real information, and then you make the decision for yourself.
That's really good advice. For the patients out there, this appears to be kind of a thought in their head, and I don't know if you've seen this scenario play out, but people who are really kind of paralyzed to make this choice, but say statements like, you know, if my job asked me to get this vaccine, that would make me get this vaccine. Or, you know, if I can't travel, I guess I would get this vaccine. You know, what do you say to that?
Well, I mean, I'm certainly in favor of whatever gets people vaccinated, right? I know that, you know, the big thing right now is some employers, some hospitals are going to start mandating vaccines, which we've seen. Bark, my dog's barking. I apologize. But we, you know, what we do see is I'm okay with whatever it takes to get people vaccinated. It doesn't matter for me if it's the travel issue. It doesn't matter if it's the employer doing it. It doesn't really matter why. I just want people to get vaccinated. But I usually tell people that the most important reason you should get vaccinated is for your own health, to keep you safe from COVID, to keep you safe from getting hospitalized from COVID. That's why you should do it for your health, and you should do it for your neighbor too. I hear a lot of people say, well, it's really just a choice about me. But in my opinion, it really is not just a choice about you, because you can infect someone else. You can infect your mother, you can infect your father, you can infect kids, you can infect your neighbors. And so it is more, we have to start thinking about this. This is not just about me. This is about the public. This is about the good of the community as well. And I think that's another way to try to frame the question and the answer.
Yeah, I mean, all three of us on here have public health degrees, and I think that you touched on something that is just so important. And if we Alabamians can rise ourselves to the occasion, we could deliver really well by thinking about others, you know, because that's the one part. I mean, if we try to stay compassionate and we think about ourselves as a community, you know, whether that incorporates people in their faith-based communities, whether that incorporates SEC football and getting back out to see an Alabama game or an Auburn game, as the picture behind you shows. So, you know, I think what we are the strongest when we think about ourselves in that way. It's not so much this choice and being paralyzed by keeping the choice, within our own hands, but just thinking about everybody and thinking about how we can move along, because nobody is telling us that we are shutting down. But if we continue in this manner, we ourselves are keeping ourselves from the very freedoms that make everybody happy. So I think you hit on that really well by talking about the community piece.
I usually tell patients too, they're like, I'm so sick and tired of this mask. And I say, I am too. I don't want to wear a mask every day. I want to be able to go to football games. I want to be able to travel. It's one of my favorite things too. But but we can't do those kind of things right now because we haven't done what we need to try to address this. I think when we were in the early pandemic, it was a different thought because we didn't have anything to do. All we could do is try to treat these people, and we were just holding on for a vaccine. And then it got here, and then we just haven't gotten the numbers to really get it to get down to a very manageable level. And so that hurts because we're tired. I know Dr. Harris is tired. I'm tired. We're tired of this too, and I know everybody is. And so we just want to try to get. We want people to be safe. We want our patients to be healthy, and we all want to get through this.
Yeah, absolutely. And that's the reason for wearing the mask, to protect others. In my neighborhood, I remember when a veteran came home and was able to see their children that they hadn't seen, and the whole neighborhood got together and started waving their flags to welcome, this veteran home. And I think if we can channel that kind of community energy that we know our Alabama citizens can do, I think we can really, we can show ourselves a way out here. One question that was asked here was about antibody levels. So either Dr. Harris or Dr. Hinkle, if either of you could speak to this, but there are some questions and concerns on whether people should check their own antibody levels after having gotten vaccinated. And if those numbers are low, does that mean something? Are clinical decisions being made by the actual quantitative number? And if so, the general public is wondering, do they need to know their antibody status?
I'll be glad to jump in on that at first, and then Dr. Hinkle may want to jump in too. So this is a real fertile area of study. A lot of people are looking at antibody levels and trying to make a determination about how do they correlate with your immunity, and do they give you clues about what your risk is, or when you might need to get vaccinated or vaccinated again, or do you need to be vaccinated at all, is one of the real questions people want to know about. If we talked earlier about people who have so-called natural immunity because they've been infected with COVID, those people do have antibodies on board. And the question is, how well do they work and how long do they stay? And so right now, the best information we have, the best science we have, says not to take those factors into consideration yet. We are still trying to vaccinate people as much as we possibly can. The best information we have about protecting people comes from what we see in people who are vaccinated versus people who have been infected and have so-called natural immunity. There's no question that natural immunity is a real thing, and some people are protected for a while, and some people are probably protected for a long while. But we are seeing thousands of reinfections in Alabama, people who have been infected before, not vaccinated necessarily, but who get infected again. And unfortunately, the risk of serious illness or dying is about the same for that second infection as it is for that first infection. On the other hand, for people who are vaccinated, when we see a breakthrough infection and we see someone who gets COVID anyway in spite of being vaccinated, their risk of hospitalization or dying is extremely low, and much, much lower than in people who only have natural immunity. There was a really widely talked about study that was released by CDC last week that looked at, in Kentucky, at people who had been previously infected, and then what happened to them if they got vaccinated or if they did not. And you're about 3 or 4 more times more likely to be infected again if you're not vaccinated than if you are vaccinated, even if you've been previously infected.
Okay, that is very helpful. Testing. Can either of you comment about testing and timing of testing and really the importance of testing?
Sure, I'll just say we certainly do continue to test. As you know, we have a high percentage of people who are getting tests now who are returning as positive. We have a lot of disease going on right now. The testing recommendations that we have are certainly anyone who has symptoms that might be COVID needs to go get a test, or certainly at least talk to your physician. You know, there may be some cases where the diagnosis is so obvious because you're in a house full of other people who have been diagnosed, for example, they may not ask you to come in for a test, but generally speaking, if you're having symptoms, you want to talk to your physician or your healthcare provider and figure out a way that you can safely be seen and tested so that you know what you are dealing with. For people who are exposed, generally speaking, we don't necessarily recommend testing, certainly not for unvaccinated people. If you're not vaccinated and you're a close contact to someone, our advice is that you need to go separate yourself away from others for about 10 days, period. And that's, in most cases, that's going to be the recommendation. Now, for people who are vaccinated, if you're exposed to someone, we don't count you as a close contact. You don't have to go home and quarantine. You can continue with your normal activity. However, because the Delta variant is so infectious, it's so easy to transmit, we actually do suggest that you get tested about 4 to 5 days after you've been exposed, just because it is possible to get infected even if you're vaccinated. And since vaccinated people don't usually have the most serious disease, you may not even be aware that you're infected. And so we do add that extra step of testing now just for vaccinated people. It's not required. It's not something that you have to do, but we do find that we pick up on some cases that we might not have otherwise known about if you do that.
And how about testing and the timeliness and whether or not somebody needs to have like a positive test as proof to then go on to get a monoclonal antibody treatment? Are the two tied together?
Yeah, so with monoclonal antibodies, those are indicated for people age 12 and up who are at a high risk for progression of disease. And so we do want you to have a test or at least have some confirmation of diagnosis. In most cases, that's going to be a test in just about every case, because that's really what triggers the decision making by your doctor to decide what you need to do. So sometimes we are up against the clock a little bit because we try to give those monoclonal antibodies to people within the first 10 days of them being infected. And so a real typical story would be you get exposed and you get infected and you have symptoms for a couple of days, and then you finally get around to calling your doctor, and then you finally get around to getting a test. And then once your test result comes back, we've got to find a place for you to go get a monoclonal infusion. So you can bump up against that 10-day window pretty easily. And so we do want to remind people that there is a limit of time in which you are eligible to get that.
Yeah. One thing I'll say about testing is obviously, you know, we do see patients that have just been exposed that want to test. And the hard part for us is a lot of times they'll come in and be like, I was around somebody today that tested, that told me they were positive, so I want to get tested. The hard part about that is you could be infected and the test is going to be negative because it's your viral loads are not high enough in your body to show positive on the test. And so the hard part for us is trying to say, yes, the test is negative today if they do decide to get tested, but you still need to be retested in 3 to 5 days, usually what we tell patients, 3, 4, 5 days, because that's about the time that if you're going to test positive. And I always tell them, look, if something changes before then, if you start getting symptomatic, that's a different story. We're talking about people that are asymptomatic exposures that are then wanting to be tested to see if they're positive. If you don't develop symptoms about 3 to 5 days, if you develop symptoms sooner, then obviously come in and get a test.
Okay. And so can y'all clarify the common presentation where, allergy season is upon us and a sniffly runny nose and the implications of how that could be a COVID infection and what to look for?
Yeah. So, like I said, this, for whatever reason, this time around, a lot of times what we're seeing, especially outpatient wise, the patients that aren't presenting to the emergency room with really severe symptoms, is more of like a sinus infection. I hear lots of patients just say, I know I don't have COVID, I just have my yearly sinus infection. I hear that 3, 4, 5 times a day probably. And the hard part is we can't really differentiate a lot of times, between those symptoms. There are some that are more classic, obviously the shortness of breath, the fever. You're not typically going to have shortness of breath, fever with allergies or something like that, right? Or even with a true sinus infection. Most of the time, that's just going to be the pressure, the pain, the congestion. But it's really hard for us to differentiate between those now. And so we do test a lot of those patients just to be sure. That's why it's important to, if you are having any of those symptoms, to not just pawn it off as I just got a sinus infection, to talk to your physician or seek medical care to see if your symptoms do fit something that needs to be tested for COVID. So.
All right. Well, I really appreciate both of you. I see that the time is 50 minutes after, so we've obviously had a real robust discussion here. I want to respect both of your time schedules. Thank you for doing this. I hope this was helpful to even just one person, because information is power. Thank you both.
Thank you for having me.
Thank you.